Oh, okay, I want to welcome everybody to the Covenant Health Research Center Lunch and Learn. And today, Dr. George Smoltzer will be presenting on the SURVIVE trial. So just some housekeeping. We are recording this. So if you don't want to be recorded, you can keep your video and audio off. Please keep yourself on mute throughout the presentation. If you have any questions, feel free to post in the chat, or you can ask them at the end of the presentation. And also, we will be posting this on YouTube at the end, so we can share with those that were not available to attend today. So I'd like to make a land acknowledgement. Spanning generations, acknowledgement of the land is a traditional custom of Indigenous peoples when welcoming outsiders onto their land and into their homes. To build respectful relationships, acknowledging the land is an important part of reconciliation. It honors the authentic history of North America, its original people, and tells the story of the creation of this country that has historically been missing. And just to reach out to Delray Dumont, who is the artist. So I would like to introduce Dr. George Smoltzer. He's a clinician scientist with a focus on neonatal, infant, and pediatric resuscitation research and large clinical trials. He is the director of CSAR for the Center for the Studies of I can't say this word, asphyxia and resuscitation at the University of Alberta, and a neonatologist within the Northern Albertan Neonatal Program, providing care to critically ill newborns. Dr. Smoltzer obtained his MD in Graz, Austria, and trained in pediatrics and neonatology in Austrian and Australia. He obtained his PhD at Monash University, Melbourne, Australia, before completing a Banting postdoctoral fellowship at the University of Alberta. He is currently a professor of pediatrics and an adjunct professor of pharmacology at the University of Alberta. He received the King Charles III Coronation Medal for his work on lung health for preterm infants. Dr. Smoltzer research focuses on understanding physiological changes during fetal to neonatal transition to improve outcomes for newborns, improve approaches to neonatal, infant, and pediatric resuscitation, and examine how physiological changes can be used to improve short and long-term outcomes of newborn and infants. And I will turn it over now to Dr. Smoltzer.
Thank you, Rhonda. I will share my slides. Okay. So thank you for the introduction and thank you for having me today. I thought like for talking about this SURVIVE trial, I will tell the story over the last 12 years or so, where we have worked on this intervention, and the journey isn't over yet, but hopefully in the next 5 years or so we will get the closure with this. Just quickly want to mention all the disclosures. In particular, the SURVIVE trial in the end was funded by CHR and Treasure Research Fund. Now, we're talking about newborn infants, which were included in this trial, and a great thing for our perspective as pediatricians or neonatologists is that the majority of babies who are born don't need our help because they can do that by themselves. The only thing we have to do really is keep them warm. And so most babies don't need our help. 10% roughly need some help with breathing, so respiratory support. But if you spend it over the world, this is around 13 million babies a year who need that help. And that's the most critical step of what we call neonatal resuscitation. Now, a step further would be advanced resuscitation, which would include chest compression as well as epinephrine in that case. Now, that's rare compared to other um, groups like adults where chest compression are much more common, but it still ends up around 2 to 3 million babies per year who require chest compression. And despite our best efforts, still 1 million of them, so a third at least, often more, would die. Now, if you receive chest compression, you certainly had a problem around birth where there was a time where you didn't get enough oxygen into the brain. And this, what is called asphyxia, then results in uh, bradycardia or a systole um, in and when the baby is born. That's the time we provide chest compression. As I said, there's a high incidence of mortality, 33% at least, often higher, as well as short-term neurological morbidities. So a lot of babies, up to two-thirds or so, or 60%, have seizures or what we call hypoxic ischemic encephalopathy, or HIE. Now, if we do chest compression for 10 minutes or more and we have no signs of life, the outcomes are getting worse. Because around 70%, apologies, around 70% would have mortality, and the survivors have a significant high rate of moderate to severe disability. Now, given those outcomes, there's always this question raised, can we do better? Can we improve the technique of cardiopulmonary resuscitation or CPR we use in the delivery room? Can it be more specifically tailored to newborns? And could that improve outcomes? What's our main problem? Well, I think our main problem is that it's rare in the sense that hospitals, like if you look at the Royal Alexandra Hospital, they would do 5 to 10 they will have 5 to 10 babies a year which require chest compression. So doing clinical studies, it's challenging because it's so rare. It's unpredictable because we never know when it's happening. It's not like when we know that a premature baby is in labor and it might be born in the next hours or within the next day. A baby who requires chest compression, there's no warning. It comes out and suddenly needs it. So that's our problem. So therefore, there hasn't been any clinical studies. And yes, many years ago we tried to change that and started to tackle that area. Now this is what is currently recommended, and I'll really focus at today's talk on 3-to-1 compression to ventilation ratio. Now, current consensus of science and with treatment recommendations, as well as what then the neonatal resuscitation program textbook says, is that if the heart rate is less than 60, despite you providing adequate ventilation, start chest compression. You use this 3-to-1 compression to ventilation ratio, which is 90 compressions and 30 inflations, totaling 120 events a minute. You use the two thumbs, which you then encircle the chest. That's preferred over using the two fingers. You can perform it from the side or from above the head. You push down the chest 1/3 of the anterior posterior diameter, and you use 100% oxygen. That's what we do at the moment. But if you look at chest compression per se, there's many factors which could affect how efficient your chest compressions are. And for the talk today, I really will only focusing on balancing compression and ventilation mainly. Briefly talk about the cardiac and the thoracic pump series as well. Why do we use 3 to 1? Well, 3 to 1 originated from the time when experts were sitting together and discussing the neonatal resuscitation program, as well as the international consensus of science and treatment recommendation. What is best to do? Well, the adults were recommending 15 to 2 or 30 to 2 as their general approach. And if you went down to the pediatric world, they were saying 5 to 1 or 15 to 2. And neonatologists in the group said, hey, hang on, we have a much higher heart rate, we have higher breathing rates. The reason why we have cardiac arrest is particularly due to hypoxia at birth. And then you get high CO2 as well. So we need to figure out a way to improve delivery of oxygen so that we can remove the hypercarbia, the high CO2. Because in adults, the majority of cardiac arrests would be a heart attack or arrhythmias. So certainly not something we see often in newborn babies. And therefore, they decided, let's do 3 to 1. Do 3 chest compressions, make a short break to give a rescue breath or an inflation, and then do 3 compressions again. So they were doing the same as the pediatric or the adults, but it's just in a shorter sequence of 3 to 1 instead of doing 15 to 2, for example. What we don't know is what's optimal. How should we do compression to optimize ventilation, to optimize the coronary and cerebral perfusion while still providing adequate ventilation? Now, this is what you do every time you would do chest compression. You would provide 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. 90 compressions, 30 inflations. See, this is what you see. This is what you do. And you have to coordinate it. You can't do continuous compression because the textbook also says that you have to coordinate it because otherwise it might interfere with the volume going into the lung. Now, that's correct. It's a problem if you would push down on the chest and you would give an inflation. That certainly interferes with how much tidal volume you would deliver. But that's only one part. Another part is, and that has been overlooked for many years, and just in the last few years, it has gained traction in the scientific community. And that's not only for newborns, because we have talked about that for a decade now in newborns, particularly our group. But it's also now recognized in pediatric and in the adult resuscitation science community. And this is a really nice study from some anesthetists here from the University of Alberta, where they had newborns up to 18-year-old children who required surgery. So they were then came to the theater, and the study was basically to gentle push on the chest, as you can see, with 160 grams per kilo patient weight. So in a 10-kilo baby, 1.6 kilos, so really just a gentle push, and then releasing the arm and just measure how much air moves in and out of the chest. And I've done that in with a face mask as well as with a protected airway, so when they had a breathing tube in place. And I really just want to focus on 0 to 1, which is like the newborn babies. And if you look at that, you can see the volume per kilo on the x-axis, and on the y-axis, you see the tidal volume. And if you look at that black bold line, this is your dead space. So the dead space is basically the amount of air which moves in and out without gas exchange. And in some of these babies where they gently push onto the chest, the volume moved is below the dead space, and in other ones, it is above the dead space. So what does that mean? Well, if the volume is high, particularly above the dead space, you risk that your lung is de-recruiting while you're providing chest compression. And that's not what you want, because you don't want that the lung gets less and less air while you're doing it. You want that the lung is recruited while you're doing it. And there has been studies in animal models in adults where they were just providing chest compression and found that if you just provide 5 minutes of chest compression, your lung is goes from 25% being atelectic or collapsed to over 75% being atelectic. So compression can de-recruit the lung. And that's certainly something we haven't thought about too much in the past. Now, this is again this 3 to 1, and if you look at the um, the waveforms below, you can see here, this is from a respiratory function monitor. You can see here the inflation, and then the first, the second, and the third chest compression. And then the next inflation, the first, second, and third chest compression. And when you analyze the area under the curve here, as well as the area under the curve here everywhere, to see how much gas goes into the lung and how much gas comes out of the lung, you can actually see that when you do 3 to 1, so one and then two, so it was 1 and 2 and 3 and breathe, and then 1 and 2 and 3 and breathe, that you actually can lose up to 4.5 milliliters for each of these cycles. Sometimes it's a bit more and sometimes a bit less, but you lose lung volume, so you don't recruit the lung. You certainly lose volume, and that is a reason we believe that many of the studies, and these are all studies done in animal models, were not successful because they found no difference in time to ROSC, and time to ROSC is the time of chest compression until you have return of spontaneous circulation again. So there's no difference because they were de-recruiting the lung. They weren't actually doing the lung a favor, and you need oxygen to get into the blood so it can go to the heart to start the heart pumping again. We went in a different approach, and in 2015 as well as in 2020, this technique was mentioned in the resuscitation guidelines as an area of investigation, which shouldn't be done routinely, but it can be done outside of the can be done in during research protocols. And how this is all started? Well, this all started 2012, so quite a while ago. And if people ask why it takes so long, well, in generally, when you have an idea in medicine, from your idea until this would become clinical practice, the average time is 17 years. So we started 2012, we are 13 years down the track, and as I said, hopefully in 5 years, um, if we prove it is better, then it might be routine. So this is just how long interventions and ideas take to get translated into clinical care. So when we did this initial simulation study and we um, used a different approach, with what we call sustained inflation, and I will get into this in a minute, we found that we can actually passively ventilate the lung. And this is actually what you want, because you want to get more air or gas into the lung so that you can oxygenate. And how is this approach differently? There's two things differently. Now, you just occlude the T-piece instead of giving positive pressure ventilation, and you do continuous compression. Now, you don't have to coordinate, you just do continuous compression. In that case, we did 90. And you occlude that for up to 20 seconds or 30 seconds, and then you just release it shortly and then put the finger on again. And then continuously you provide chest compression. Now, when you look at the difference, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, and here you're just continuously doing it, holding it. simulation studies we have done with people at the Royal Alec as well as at the University Hospital. At the Royal Alec, they have participated in this trial, so some have experiences in doing it. At the University Hospital, they would have never participated in the trials because there's no deliveries happening. Both found it is much easier to perform compared to the standard technique because you don't need to coordinate, you have much less mental workload. What else is different? If you look at the waveforms on the left again, you can see this, what I described earlier. You see the inflation and then 1 and 2 and 3, inflation 1 and 2 and 3. Here on the right, during the sustained inflation, what does the sustained inflation do? Well, a sustained inflation provides a distending pressure like CPAP, but instead of using a CPAP of 5, we use a CPAP of 30. And when you squeeze the chest, as I said before, air comes out. And you can see this because here, see the flow comes down. So air comes out. But the moment you release the chest, air goes back in. And then you squeeze again, air comes out, release, air goes in, and so on. And that's your passive ventilation. You push the air out as you do with both techniques, but when you release, so doing the chest recall, air goes back in. And when we did this in our animal studies, that's the first step we did. We found that when we did this and compared that to the standard approach, you can see that ROSC, which is the time to return of spontaneous circulation, was roughly 75% faster. So quite successful, surprising for us. Mortality was also better. So that's certainly something which was quite exciting when we initially did our first study. And again here, no, my cursor doesn't work. But if you look on the right, and you can see now the difference with the chest compression superimposed with a sustained inflation, we call that CC+SI. The air goes in and out, and you actually gain volume up to 2.3 mils per cycle. So over time, you gain volume. So you don't de-recruit the lung, you recruit the lung. So you reduce your potential atelectasis. You can push down the liquid air interface because at birth you have a lot of lung liquid in your lungs, and so you can oxygenate better. And that's certainly one of the advantage with this approach of CC+SI. The other advantage is how CC+SI works on the blood flow. Now, during chest compression, there's two series. One series says, okay, because the heart is positioned between the spine and the sternum, and if you push the sternum down, you squeeze the heart like a sponge, and then you actually eject blood. That's how this cardiac pump theory works. The alternative theory is called thoracic pump theory. What does that mean is, so when you provide chest compression, regardless where the heart lies, because you provide chest compression, this increases your intrathoracic pressure, and this increase in intrathoracic pressure lets the blood flow passively through the body. Now, that's chest compression. A sustained inflation also increases your intrathoracic pressure, which means if you combine both, you get even better blood flow. And we have shown that in our animal studies. If you look at the graphs on the right, if you look at A, you see the change in pulmonary artery blood flow, which is significantly higher with CC+SI. The same with the carotid blood flow to the brain. So you get more blood flow through the pulmonary artery to get better gas exchange, and you get more blood flow through the brain, so you get more oxygen in the brain to reduce potential brain injury. The pulmonary artery pressure, that's the table on the left, as well as the mean arterial pressure were also both significantly higher. So overall, better hemodynamics. Now, what people always worry about is well, you're providing intervention which increases your intrathoracic pressure, but The problem with that is that your venous return to the heart will be impaired. So you might get more congestions of blood in the brain, and that wouldn't be good. But if you look at the CVP, the third line on the table, then was not different. So yes, this approach of CCSI increases your intrathoracic pressure, but it doesn't impair your venous return, which is what you'll want, because that certainly then doesn't interfere with any of the negative effects of having impaired venous return. And then, as I said before, when you just important is the left one, where we compared 3 to 1 with CCSI. You can see that when you do chest compression, um, your intrathoracic pressure is significantly higher, which is what you want. On the right, we tried something differently. We tried a different technique, which is used in general in the pediatric resuscitation, where they just provide continuous chest compression, and every 2 to 3 seconds they give a ventilation that is called non-synchronized or asynchronized ventilation. And it doesn't matter whatever technique you use, CCSI will increase your intrathoracic pressure significantly compared to the other technique. So it does that. Well, we were thinking it does, and will have contributed to the improved outcomes. Now, after doing several studies in newborn piglets, because you need to fine tune and need to investigate if there is any harm or so. All the studies we did, we found that up to 75% the time to return of spontaneous circulation is faster. We had lower mortality. We needed less epinephrine because they came back faster. We had improved hemodynamics, systemic as well as regional. We had improved ventilation because the minute ventilation was higher. We were passively ventilating, and we never had a pneumothorax, which was a concern. And if you looked at lung and brain injury markers, they were all the same. They were not different in our intervention compared to standard, which is what you want as well. So it was time to move from the lab into the delivery room. And we started with a small study. It was just a pilot where we just got 5 babies with the new approach and 4 babies with the standard approach. And again, if you look at the left top, you can see that these were all in infants less than 32 weeks. The time to ROSC was again around 75% faster and quite comparable to what we saw in the lab, where we had like 34 seconds and 140 seconds or so. So relatively similar, which just showed, yes, what we found in the lab is true when we translate it into the delivery room. The table, the blue table, just shows the respiratory parameters, and just shows differences which are understandable. Because if you do 3 to 1, you give 30 inflations. When you do CCSI and you push down, air comes out, you release, air goes in. So each chest compression is automatically a ventilation as well. So you will have 3 times as many ventilation, and that's significantly different, understandable. You can see that the towel volume, the VT, was the same, but if you now do the towel volume times 29 versus the towel volumes times 91, you will see that the MV or minute ventilation will be significantly higher. But that's good because you want to get more gas in. And because we used a CPAP of 25 in that case, in the delivery room, the PEEP is around 25, because that's your distending pressure. So no surprises here in what was different, but importantly, it got better. Like the time to ROSC was shorter, and there weren't any harms. Yes, 2 babies died in the CCSI group, but these babies were like 24, 25 weeks, so extreme premature babies. And in general, even particularly with chest compression, there's an extreme high rate of mortality. So not optimal, but certainly something we were building on. And this is now the SURVIVE trial, the first step in the next step in that journey. where babies also would have been followed up within the Guanans hospital. The Survive trial, we said, okay, let's see what we can do. And for any clinical trial, you need a primary outcome, which is the thing you define as your most important outcome. And talking, yes, I can understand that mortality potentially for many would be, or that would be the most important outcome, and that's absolutely true. But as no one has ever done a study like this in the delivery room, um, we landed on the time of chest compression or the time to return of spontaneous circulation. Why did we land on that? Because for any clinical trial, you use something which is an independent advisory committee, which is a committee which helps you with the trial, but is not involved in any aspects. And this independent uh, committee is called Data Safety Monitoring Committee, or DSMB. And that normally consists of experts, at least a couple of experts in the field, uh, as well as a statistician. And they advised to use this outcome as the primary outcome. Then we looked at how many babies we need, and we looked at what's the time of chest compression in our unit, and we landed that we would need 218 infants to and that would be roughly not 104 but 109 infant in each group. And we thought, okay, given what we saw so far from the previous studies, we could reduce the time to ROSC by a third, so 33%. So hypothetically, if you would have done 10 minutes, and 10 minutes is a rough estimate of what most babies need, then we might be able to get it down to 6 minutes or 6.5 minutes. And I thought that would be a good success. And we will include all babies from 23 to 42 weeks, whenever they require chest compression in the delivery room. Now, whenever you do clinical trial, you have different ways of how you randomize. And the standard approach is often that you maybe open an envelope just before you do something, or you log into a computer program and type in some data, and then the computer tells you what group. An easy way is flipping a coin as well. And we knew that we can't do that because everybody who's ever been in a delivery where they need a chest compression, that before we start chest compression, someone starts thinking, hey, there's a study, we need to do randomize and open an envelope, know how challenging and impossible that is. So we decided to do what it's called cluster trial. What does that mean? Well, we told the hospital, you are going to do 3-to-1 or CC+SI for 12 months. And once the 12 months were done, you switch to the other intervention. So the whole staff was trained for one intervention and then got switched to the other intervention, got trained again and switched. So in that way, we were reducing this potential of missing babies because people weren't thinking about doing this. Because, as I said, even at the Royal Alex and in the hospital, it happens 5 to 10 times a year. So you might not participate in any of them for several years. So that way, we assured that at least it's only one intervention available. And each of these markers represents sites around the world who were interested in participating in this study to get this done, because it was quite interesting results so far, what we found. Unfortunately, a short period into when we started, this study was published. And this study was called the SAIL trial. And what the SAIL trial did was in babies who were born 23 to 26 weeks gestation, so really in the extreme premature babies, when they were born and required positive pressure ventilation, the idea was to do just normal positive pressure ventilation as we do it routinely nowadays in all babies, or to give up to 2 sustained inflation of 15 seconds. So instead of giving short puffs, giving a really long puff. And the hope was that this will reduce bronchopulmonary dysplasia or death at 36 weeks in these extreme preterm infants. Unfortunately, it increased mortality, and you can see it on the right, from 59 was in the standard approach to 63.7, so 4.7% higher. And that was a problem because it used the same intervention. Like it used also sustained inflation, not chest compression sustained inflation, but it used the sustained inflation, and it was harmful. So we had to stop the trial because this was a problem because we didn't want to harm babies with that approach. So we stopped the trial or paused the trial because of this publication. We talked to the steering committee, which is the committee who runs the trial, and the data safety monitoring committee, and landed on only including preterm babies who are 28 plus 0, as well as term infants. And then we restarted. We then tried to submit it to many other sites, and there were several ethics boards around the world who said, well, great study, we would like to participate, but we would like to see a bit more data. So we wait for the first interim analysis. And we said, well, we weren't 100% happy with it, but we said, okay, we can do this. We also had quite strict stopping rules. So hypothetically, if and stopping rules are built into a trial to make sure that there is safety for all the participants. And they were so strict that if there would have been one death more with that CC+SI compared to 3 to 1, the study would have been stopped. So really, really strict. But the ethics board wanted to wait, and that was fine with us. We also had quite a challenge to get contracts signed. And if you do a study with each hospital, like even if I just do a study with the Greyhounds Hospital, there's a certain contract I need to sign so that I can get the data. Because no one is allowed just to look at the data of any patients. And that always takes 6 to 9 months in general. That's not something which is fast done. And we know that. But if you go and do a study outside of Canada, you also need an insurance. And the insurance is there to make sure that if a patient is harmed, that they get a payout. And it was extremely challenging to get an insurance company to give us an insurance for sites around the world because they were afraid of the risk that when a newborn receives chest compression. So it took us 3 years. And then we finally got many sites ready. And then COVID came. And as you all know, when COVID started in 2020, we had to stop all studies. We weren't allowed to start new studies, and it was the same around the world. So we were really unfortunate when that happened. And as you can see from all the colorful dots we had on the screen, this is what was left. 4 sites, 2 in Canada and 2 in Europe who were participating in the end. Not what we planned for, but this is what we got for. And instead of having the 109 patients per site, per group, we only ended up with 11 and 14. Very disappointing overall, but we couldn't continue because we were already doing this for 5 years. And after 5 years, it's challenging to expand or renew a grant because you need to ask for an extension for a year. And it's challenging to get extension when you try to do these studies. But nonetheless, we got some extra data, which is great. So here you see the demographics of the babies included, and you can see that the majority of babies are late preterm babies, around 34 weeks. But overall, there was no difference in any of these demographics, which is what you want because you don't want differences there, which then potentially can explain your outcomes. The intervention we did in the delivery room, there was also no difference. And I think the really most important one is the one where it says switch to 3 to 1 in the last part of this table. What was this? Well, we didn't tell the team to switch in general, but we had a fail-safe in, because again, this was the first time done, that if you provide chest compressions for 5 minutes and there is no ROSC, then please switch back to 3 to 1 because that's standard of care. So this was in there uh, as a fail-safe mechanism. And now to our primary outcome. We had time to ROSC. And what you can see is that with CC+SI, it was 90 seconds. And with 3 to 1, it was over 600 seconds. So over 10 minutes versus 1.5 minutes. Now, it wasn't statistically significant because the numbers are too small, but it follows the same trend which we saw in the animal study, which we saw in a single center study, and which we saw in a study at 4 sites. So as you expand and do it in different places, and you find the same results, it's not something where people then say, yeah, well, it's just because you guys are experts and know how to do this. This is just something which you can confirm over time. So it seems that if you use this approach, you get the babies back much faster, even though because the numbers were too small, it's not significant. And if you look at what the normal duration is, you can see that it is somewhere between 6 to 9 minutes on average, median time. And having 10 minutes, we're almost in the time frame what the databases say as well. Survival in our standard group was 42%. In the registry, it can be up to 60% survival. We had 82%, so even better than that, which is exciting because only 2 of the 11 passed and 9 actually survived versus only 6 in the standard group survived. So far, quite exciting, even though nothing was statistically significant. And we also didn't get any harm. So no pneumothoraces, no intraventricular hemorrhages, or any other brain injury, which was also exciting because it just shows that it's not harmful. So in summary, we found no difference in anything because the numbers were too small, but we saw a nice trend in the same direction as we saw previously. We had no safety concerns. And if you put now the 2 studies together in what we call a meta-analysis, you can see that if you look at the bottom one, and that's called a forest plot, because of each study represents a dot, and that can, if there's many studies, it look like a forest. You get on average 2 minutes less chest compression, which it's a good outcome because every minute chest compression is associated with roughly 10% higher risk of mortality. Mortality isn't different, but it's a trend. But this is exciting news because knowing this, we can really build on for the next step. And the next step is Survive 2. And on the left, you see again the steering committee with Po-Yin Zhang, which I guess many of you know because he is the current site director at the NICU at the Greynuns. We have Brenda Law next. She's a neonatologist at the Royal Alec. Gerhard Pichler, he's in Austria. He will run it there in Austria. Anne Solovak, she will run the trial in Norway. Then we have Betsy Pillon, parents representative from Hope for HIE. We have Taimai Lu and Liz Astelos who will run the follow-up. Anoop Kataria who will run the trial or organize the trial in the US, and Pia Wintermark who is a brain expert. And we have again our DSMB who will have an oversight before everything is working and everything is safe for the patient. We're gonna go to mortality, and this will be if this mortality. This time we need 250 babies, or 278, and from the other studies, we will only include preterm babies 28 weeks and term if they require chest compression. This time the hospitals will have more time, so they will be randomized for up to 2 years doing one approach. We collect a lot of data. We will also look a long-term follow-up at 2 or 3 years of age and see how these babies do at that time. And this is the sites we submitted to the CHR, to the Canadian Institute of Health Research for funding. And you can see several sites in Canada, but also in the US, Norway. Norway already has ethics approval as well as we in Edmonton and Calgary. Uh, we have Austria, we have several sites in India, we have South Africa, we have South Korea, we have Pakistan, we have Ireland and the UK, we have Zimbabwe, Chile, Australia, New Zealand. So we have quite a global alliance, and we'll be able to do this not only in level 3 NICUs. We will also have lower and middle resource settings and low and middle income uh, countries, because what we want is that this can be done everywhere, not something which can be only done in high income countries, because that wouldn't be helpful for many babies around the world. So we really hope that when we have all this, that we can do this in any of these places. And I just say thank you to all these people here on that screen who over the last 12 years have worked on studies on CCSI and brought us where we are at the moment. If you want to know any more, these are just my social media contacts where you will find more information, any updates as well on where we are with the journey. And now I'm happy to take any questions. You're muted, Ronald.
Can you hear me now?
Yeah.
All right, great. So what's your, I was trying to quickly add them up. How many babies are you looking at for your Survive 2?
556.
556. So that's more than double.
Yes.
You showed a lot of tenacity keeping this this going
Oh, yeah.
over these years with quite a few interruptions. I'm not seeing any questions in the chat. Does anybody want to unmute and have a question for Dr. Schmolzer? Okay, I'm not seeing any questions. So I want to thank you very much for presenting today. That was an incredibly interesting study and very hopeful.
Oh, yeah. Thanks. Appreciate it. Yeah, I hope so too. Well, July 3rd or July 15, we will know if we are lucky and get funded or if you have to reapply. Well, we'll see.
Okay, that'd be great. Keep us
Yeah,
posted.
we will. I will.
And I will be posting this recording on YouTube.
Yes.
And we will forward the link out to yourself as well as all the attendees and all those that registered that couldn't
Oh,
attend
yes, please.
today.
Then I will post it on my social media too.
Perfect. Well,
Cool.
thank you so
Appreciate it.
much.
Thank you.
All right. Bye-bye.
Thank you very
Thanks.
much.
Have a good
Thank
day. Thank
you.
you, and more.